If you have ever heard a woman say that when she was pregnant, her heart doubled in size, she was literally correct. During pregnancy, the heart develops functional cardiomegaly. In other words, the heart becomes larger because it is required to perform a much greater amount of work than it normally would. It is no longer responsible for supplying blood and oxygen to only one person. It is now supporting both the mother and the developing baby. As pregnancy progresses, the body's demand for circulation increases, and the cardiovascular system adapts accordingly. These adaptations are not signs of illness. They are normal physiologic changes that occur in response to the increased workload of pregnancy. Because of these changes, vital signs often look different in pregnant patients than they do in non-pregnant patients. This is why it is so important to understand what is physiologic and what is pathologic. A number that would be concerning in one patient may be completely normal in another. Pregnancy changes the rules in several important ways, and providers must recognize those differences. Let's begin with blood pressure. In a non-pregnant female, systolic blood pressure typically runs between 100 and 130. During the third trimester, however, the expected range changes slightly. The lower end is around 102, and the upper end can reach approximately 144. On paper, a systolic pressure of 140 may appear elevated. In many patients, it would be, but in a third trimester patient, that number may simply represent her normal physiologic baseline. The same principle applies to diastolic blood pressure. In a non-pregnant female, diastolic pressure generally runs between 56 and 80. During the third trimester, that range may increase to approximately 62 through 85. Once again, numbers must be interpreted in context. Looking at a blood pressure without considering pregnancy status can easily lead to an incorrect conclusion. Consider a blood pressure of 140 over 85. In a non-pregnant patient, that reading would generally be classified as stage 2 hypertension and would immediately attract attention. In a third trimester pregnant patient, however, that exact same blood pressure may represent her baseline physiology. The number itself has not changed. The context surrounding the number has changed. This is one of the most important concepts in obstetric assessment. Context is everything. Vital signs should never be interpreted in isolation. They must be interpreted in relation to the patient's condition, gestational age, symptoms, and overall presentation. Now let's discuss heart rate. Heart rate fluctuates slightly throughout pregnancy and often becomes faster at rest during the later stages. This occurs because the heart is working harder and moving a greater volume of blood throughout the body. The cardiovascular system is under increased demand, and a modest increase in heart rate is one of the ways the body compensates. For that reason, providers should not panic over a resting heart rate of 100 in a third trimester patient if she is asymptomatic. Numbers alone do not tell the whole story. If the patient is comfortable, alert, breathing normally, and not experiencing concerning symptoms, a resting heart rate of 100 may simply reflect the physiologic demands of pregnancy rather than disease. Next, let's move on to respiratory rate. In a non-pregnant adult, the standard respiratory rate is generally considered to be between 12 and 20 breaths per minute. During pregnancy, especially during the third trimester, respirations often become more rapid and more shallow. This happens because the baby occupies a significant amount of space within the abdomen. As the uterus expands, it pushes upward toward the diaphragm. The diaphragm has less room to move, and the mother may feel as though she cannot take the same deep breath she could before pregnancy. As a result, the body compensates. Rather than relying on deeper breaths, it often increases respiratory rate while maintaining adequate oxygenation. This is a normal physiologic adaptation. The patient may breathe faster, but oxygen delivery remains effective. An SpO2 of 98% with a respiratory rate of 24 is compensatory. The body is adjusting to the mechanical effects of pregnancy and maintaining oxygenation successfully. In that situation, the respiratory rate alone should not cause alarm. An SpO2 of 88% with a respiratory rate of 24 is a completely different situation. In that case, oxygenation is no longer being maintained adequately. The problem is not the respiratory rate itself. The problem is hypoxia. This distinction is critical. Providers should treat the oxygenation problem, not the number alone. A respiratory rate must always be interpreted together with oxygen saturation and the patient's overall condition. Speaking of SpO2, it does not normally change in pregnancy. Oxygen saturation should remain within the normal range. Pregnancy itself is not considered an explanation for abnormal oxygen saturation. Any abnormal SpO2 should be treated exactly as you would in a non-pregnant patient. Do not write off hypoxia as pregnancy-related. If a low oxygen saturation would concern you in any other patient, it should concern you in a pregnant patient as well. Now, for the paramedics and EMTs who can read an EKG, and if you cannot, this is still valuable information to keep in your mental database. Pregnancy can produce several EKG findings that may initially appear abnormal but are actually considered physiologic. These changes occur because of the cardiovascular adaptations associated with pregnancy and the presence of functional cardiomegaly. You may see a shorter PR interval in the third trimester due to cardiomegaly and physiologic tachycardia. This finding can appear unusual if you are not expecting it, but it is recognized as a normal physiologic variation associated with pregnancy. There is no significant change in QRS duration. Despite the structural adaptations occurring within the cardiovascular system, the QRS complex generally remains unchanged. You may also see inverted T waves in leads 3 and V2. In another clinical setting, these findings might prompt concern. In an asymptomatic pregnant patient, however, they may simply represent normal physiologic changes. You may see non-pathologic Q waves in leads 3 and a VF. Once again, these findings are recognized as normal variants during pregnancy when they occur in the appropriate clinical context. And you may see a prolonged QT interval during the second or third trimester. This is another physiologic finding that can occur as part of the body's adaptation to pregnancy. All of these findings are considered physiologic unless the patient presents with significant cardiac symptoms. The presence of EKG changes alone does not automatically indicate disease. Symptoms remain critically important. Substernal crushing chest pain, radiation to the left arm, diaphoresis, or syncope should always be taken seriously. These findings may suggest true cardiac pathology and require further evaluation. However, when the patient is asymptomatic and these EKG findings are present in isolation, they are generally considered normal variants associated with pregnancy rather than indicators of disease. To put this in perspective, the cardiomegaly of pregnancy would be potentially fatal in almost any other patient population. In most situations, enlargement of the heart is something providers view with immediate concern. It is often associated with significant disease processes and poor outcomes. In pregnancy, cardiomegaly is the body's impressive compensation mechanism. It is a physiologic adaptation designed to meet increased circulatory demands. Rather than representing failure, it represents successful adjustment to the demands of supporting both mother and baby. Recognize it, respect it, and do not treat it as disease unless disease presents itself.